They commonly say that if doctors practice all the time, when will they become perfect? It constantly amazes me that we still have so many controversies after working for so many years with such voluminous literature.
If there is a doubt, if any of the 4 or 5 tumor markers which we do, if any of them show a deranged value, then I don't try to take any risk. We refer the patient for an open surgery to the oncosurgeon. Out of my 25 years of practice, what I have learned, it takes 2 years to learn how to operate. It takes 20 years to learn when not to operate.
Hi, I'm Jaydeep Tang. I'm a senior gynaecologist. I'm the co-founder and CEO of Pluro. Welcome to the podcast, and I'm delighted to have this conversation with Dr. Rajesh Modi, a founder partner at Pluro and one of the most eminent gynecologists and endoscopic surgeons of our country. Welcome to Pluro, Rajesh. And I would actually like to discuss with you several issues and controversies which even now plague doctors. They commonly say that if doctors practice all the time, when will they become perfect? And it is a truism that we call our work as practice. I would like to believe that we call it as practice because every patient teaches us something new, every surgery and every procedure teaches us something new. But still, it constantly amazes me that we still have so many controversies after working for so many years with such voluminous literature on topics like fibroids, endometriosis, unexplained infertility, tubal factor of infertility, and so on. I know that you were actually one of the pioneers of what is now called daycare surgery. You were perhaps one of the first people who used to do this, where you used to do a surgery in, let's say, a workshop in the morning, and then in the afternoon, you actually had the patient coming up in the auditorium and talking to the audience.
Yes.
So let me start with that, Rajesh. And I believe that even at that time, there were controversies about it.
Yes.
And I think one of the major controversies at that time perhaps was, what is the need?
Correct.
Why can't you keep the patient for a day or two, let the patient be comfortable and then go home? And I remember you used to say that if the patient's comfortable on day one, why can't she go home?
Yes.
And so I'd like you to talk a little bit about why you thought that this was a good idea in the first place. Secondly, what do you do in particular in your surgery to make sure that patients are able to be so comfortable that they can be discharged on the same day? And lastly, have you ever had an experience where patients have actually needed to be readmitted after you have discharged them on the same day? Let's start with that and then take it from there.
Yes. So thank you, Jaydeep, for the invitation to interact with you over here today. And it's a pleasure for me to be a part of the Pluro chain and hope to have wonderful work happen together. As far as daycare hysterectomy or daycare surgery is concerned, the concept started with a patient wanting to go home in the evening. Very surprisingly, initially when I started off, maybe more than 10 years back, patients were not told that they have to go home in the evening. And it is only when, surprisingly, a couple of patients, when they were comfortable enough in the evening, actually expressed their desire that, is it all right if we go home and sleep? If there is any problem, we'll immediately come back to you because you are anyway here in the hospital. That is what prompted me to start developing the concepts and refine the process of anesthesia as well as the post-op surgical care. Thereby, we were able to allow the patients to go home in the evening. It is not about not wanting him to stay for a day or two extra. But as you mentioned, what I always believed is, if the patient is genuinely comfortable and willing to go home in the evening, then why not?
Sure.
In our country, at least, inherently, the women are very family-oriented. Even if the patient or the woman has been operated in the hospital, her mind and her heart is still at home. So given a choice, you will find that women would prefer to go home early. I think the difference what makes the patient decide to stay back in other places and not at my places, the confidence in which they are recovering So my patients, they are very confident that they are comfortable, they have recovered and they are okay to go home. Unless this confidence is transmitted by the surgeon to the patient on the day of surgery might not want to go home because she is worried that in case she goes home and has a problem, then who will manage the situation?
Absolutely.
But like I said, given a choice, every woman would definitely want to be home as early as possible, even if it is on the same day of surgery. Even though she may not do any work or she may be resting at home, but being at home and being in her safe or own environment is what makes a difference to the patient. So effectively, it is patient-oriented concept, not a doctor-oriented concept that I would not want to have my patient hanging around for a day or two extra. But it is for the patient's comfort. Personally, at my place, though I have been doing daycare for so many years, more than a decade, touchwood, coincidentally, I have not had a patient getting readmitted on the next day or in a couple of days. We have had a few admissions of delayed problems coming back for readmission, which would be 2 weeks or more after the surgery.
Which would not affect the fact that they stayed for a day or
2 days. Yeah, correct. Yeah. But otherwise, even I would not want to send the patient home if I'm not confident about everything being comfortable. So there are situations like suppose patient is having some cardiac issue, patient is a patient of renal problem, where my anesthetist also refuses to let them go home in the evening because he would be more comfortable having them under observation for 2 or 3 days. So it's not that we send every single patient home in the evening. It's a choice which we offer.
Sure. No, I think you're absolutely right. It was actually born out of a patient's desire to go home. And I think that's really very important. It's not something which is imposed on the patient to say that just because I am a very good surgeon, you should go home in the evening. It doesn't really work that way, right? If a patient says, for example, and this is something I do myself, what we tell the patients is that from my side now, you are ready to go home. You can decide now when you want to go. Very true. So if I go and see a patient, let's say in the afternoon, and I've operated on her, and I think that she's fine to go home, then we give a choice to the patient to say that I think you can go home medically now, but if you are comfortable, you go. If you are not and you would like to stay for a day, nothing stops you from staying. There is this misconception that daycare surgery is something that is promised to the patient, but I don't think that is the case. No, say that if you're comfortable, we will let you go.
Very true. Very true.
Right? Rajesh, going into a little nuance about this daycare, what do you do at your center, particularly in terms of anesthesia, post-operative care, simple things like making sure that the patient can take orals and food, or that she's passing urine adequately. So what are the medical measures that you take to try and make sure that patients are first very comfortable, and then because they are comfortable, they're able to go home?
Yes. A lot of it depends on the anesthesia protocol, definitely. Key important factors. We do not use nitrous oxide. Okay. We use only oxygen and air. You have to have a mixture. Either it is oxygen and air or it is oxygen and nitrous oxide. So we specifically have stopped using nitrous oxide for more than a decade. That allows us to start the oral feed immediately post-op. If you have not used nitrous oxide, there is absolutely no hampering of the bowel motility. If you use nitrous oxide, there is a certain amount of bowel motility which is hampered. So you have to have the patient NBM for 6 hours, 8 hours after the surgery, which is not required if you have not used nitrous. The anesthesia protocol is made in such a way that the residual impact of the anesthesia drugs is bare minimal. Nowadays, with the advancement of the medication, the recovery period is almost instantaneous. Like initially, when we started, we would have a half an hour period where the patient is lucid, not completely out of anesthesia. But now that is hardly few minutes. The moment you extubate the patient and a couple of minutes later, the patient is completely alert and comfortable. So the changes in the drugs also have helped in the daycare process. Surgically, the fineness of the surgical steps, the results which include minimal blood loss, minimal tissue trauma, and a comfortable tissue handling during surgery is what ensures a pain-free recovery for the patient. if there is not much of pushing, pulling or struggling with the tissues, obviously the post-op edema is less. Then that consequently translates into less post-operative inflammation and pain. These are the key points. Apart from these, there are minor small things like we put 1 liter saline inside, which also aids in not giving saline in the post-op period. Psychologically, if the patient is having an IV line going on, they don't want to get up.
Right.
The fact that I put saline in the peritoneal cavity, slow absorption over 10 hours takes place. I don't give IV fluid in the ward. The patients feel that they are better off.
Sure.
So the post-op mobilization is faster. To a certain extent, it starts right from the time when the patients meet me for the first time. So when I talk to my patient and tell them that routinely we do as a daycare, patients come in the morning, get operated, go home in the evening. The patient's mental state starts accepting the fact that she has to get up, walk around and go home in the evening.
Right.
So everything comes together to give the end result.
So it's a process.
Yes.
It's a process which starts right from the time you see the patient for the first time. It's also a way of generating expectation and thereby having a result delivered up to the expectations in a way.
Yes.
And it's also the fact that the anesthesia that is used, and I think that point that you made about not using nitrous is actually a very good point because you completely change the way the bowel reacts with the anesthesia. Besides all this, for example, is there anything particular in terms of, let's say, instrumentation or in a way, factors which are not directly related to the fact that you're operating? Do you think that any particular instrument, any particular technological advance, which is nothing to do with you individually, but do you think, for example, that investing in expensive instruments is worth it? Do you think that you should probably have the best of technology, which you do, to operate, because of which you are able to deliver the results with such precision?
No, not really. My daycare concept started with basic equipment. The daycare concept has refined to a certain extent based on the protocols. It has not refined too much based on the refinement of equipment which I have upgraded in the last decade. So today, though the equipment which I am using is the topmost quality, compared to one and a half decade back, where we were using basic equipment, the daycare concept has not evolved to that extent. So it's not equipment based. Anybody with a decent setup, if they follow the same protocols, should be able to achieve the daycare concept in their own clinic.
So it's as much the machine as well as the man behind the machine. I think both the things have to be taken into account to deliver perhaps what would be an exceptional result for the patient.
It's not only my surgical skill. The protocols which we have put in place, sure, like I mentioned about the anesthesia part, they play an equally important role.
Right. So I think, Rajesh, that's very, very interesting. And I think, in a way, that segues very nicely into the next part, which is a question on fibroids. I know that patients would like to believe that fibroids are because of something which they have done. A lot of patients ask me, I ate this, I took oral contraceptive pills, I had, for example, either too few or too many pregnancies, and so on and so forth. We know that that's not the case. Fibroids could just about occur to anybody. It is also a truism that the presence of fibroids does not mandate surgery. There has to be a reason, or there has to be a symptom, or there has to be a certain size of fibroids to mandate surgery. And while laparoscopic surgery has made great inroads into the surgery of fibroids, there are some who believe that laparoscopy actually took a giant step backwards when the whole morcellation controversy occurred. For those of you may not know, a patient who had a cancer of the uterine fibroid underwent a fibroid surgery by laparoscopy. We normally break up the fibroid into multiple pieces, and in doing so, that cancer got disseminated. This led to a whole movement in the United States, which led to the FDA, actually banning the morcellation procedure. And some believe that was a giant step backward for... We have now come up with solutions, precautions, processes to make sure that it doesn't happen. But I'd really like your take on this as to, if there is a morcellation to do, what would you do before you do that surgery? Do you have limits on the size of the fibroid before you decide that no, now I would like to actually do an open surgery vis-a-vis a laparoscopic one? And how do you take care to make sure that these things don't happen? In other words, what is your preferred technique of morcellation?
Yes. So there was a time when morcellation had to take a step back. But like you mentioned, there are now protocols in place which allow you to do the morcellation and avoid having the dissemination. So the technique is called as in-bag morcellation. Once the fibroid has been separated from the uterus, the repair of the uterus has been completed, the fibroid is placed in a sterile bag. And then the morcellation is conducted within that bag. This allows whatever dissemination is going to happen to remain contained within the bag, and then the bag is removed intact. So in-bag morcellation, also labeled as contained morcellation, that we are not allowing the cells to spread, has taken care of the issue which came up with the cancer spreading because of morcellation. Morcellation still I am preferring as the method of choice for removal of fibroids, and with this safety measure in place, there is no further risk of malignancy being spread because of the morcellation. The advantage of doing laparoscopic fibroid removal or laparoscopic myomectomy still far outweighs the concept of whisking the spread of malignancy, especially after using an in-bag morcellation.
Sure.
So by choice, it is definitely a better option to do a laparoscopic myomectomy for laparoscopic fibroid removal. The unfortunate incident which happened in the US, ultimately it ended up teaching the entire medical fraternity a lot, and the advancement which has now happened after that has taken care of the issues which were happening at that time.
Sure. So I, for example, am a little conservative for my fibroid surgeries. I, quite frankly, feel that you have to weigh the risk and balance not only in terms of spread of malignancy, but also in terms of the time taken for surgery, etc., etc. So without sort of disagreeing with you in any way, I would also like to point out that the decision on whether to operate a fibroid by open surgery or laparoscopy, in a way also depends on both the choice the patient makes and the surgeon who's operating.
Yeah.
And I don't think there are any rules, or there should be any rules cast in stone about whether a given fibroid needs to be removed laparoscopically or by open surgery. It's usually a fluid and dynamic situation. But given the fact that most fibroids can be removed laparoscopically, there will still be an occasional fibroid which will need open surgery.
Even after operating for more than 25 years, at least once in a year, I am still opening up the patient.
Exactly. So, I mean, we should not, stigmatize.
Yes.
I would say open surgery.
There are at least 10 times in a situation and 10 times in a year where I have to talk to the patient that I am doing it laparoscopically. But if I find at any time that by opening up, I will be able to give you a better result, I will open up and do a laparoscopy.
Absolutely.
May not be required in all those 10 times, but at least one time I would definitely open up in a year.
We were talking about endometriosis, Rajesh, and the point that I was making was that endometriosis cannot be seen as a homogeneous entity. There's a lot of heterogeneity within the way endometriosis presents, the way endometriosis works. For example, I believe that when there is pain associated with endometriosis, it's almost like it's a disease which is different.
Correct.
Than when it is not associated with pain. And I think it's a little unfair to compare medical versus surgical treatment when the population which needs either treatment is quite different. There has been a lot of talk about this recently. I'd like your take on that.
I completely agree with the thought which you are putting across. From the perspective of treatment, unfortunately in endometriosis, there is nothing which is 100% curative.
Absolutely.
You can treat the patient medically as long as the medicines are effective. The problem of endometriosis is suppressed, patient is comfortable. It can be prolonged medical treatment, maybe over a period of 5 years, 6 years, there is no harm in it. The moment the medication is stopped, there is always a chance that the endometriosis may come back again. Same is with the surgical treatment. So today, if I am operating on a patient with a chocolate cyst, I am removing the chocolate cyst, there is no assurance that it will not repair again. If I am talking about operating on a patient with pelvic endometriosis, how much ever adhesiolysis I am doing, how much ever clearance I am doing, it is not 100% curative. There is always a possibility that she will have a recurrence of endometriosis, because as long as she is young, as long as she is having a uterus, as long as she is having her menses, the chances of endometriosis coming back will always be there. So in that case, from my personal judgment, I am a little conservative, more in favor of medical management, and this absolutely necessary. I would also not prefer to directly going for a surgical approach.
Even if you get operated by the most skilled surgeon in the world, you're still going to need follow-up. There is still a chance that there may be recurrence, and you need to essentially take care of yourself even beyond the surgery. My feeling has always been, Rajesh, that for patients who are young and have not had children, I would actually like to operate the closest I can to when they want to get pregnant.
Very true.
And that will make sure that, they don't have repeated surgeries there. And Rajesh, is actually very interesting now that you're venturing into IVF after such a wonderful and storied career in endoscopy. For those who may not know, Rajesh was recently conferred the fellowship by the Sri Lankan College of Obstetricians and Gynaecologists. So I'd like to know a little bit about how that happened and, what led to the Sri Lankan College conferring this very prestigious fellowship on you.
I have been giving training to gynecologists over the last 15, 16 years. So people come to refine their surgical output in the courses which I am conducting. And it coincidentally so happened that I have had a lot of Sri Lankan gynecologists coming to Akola to take the training at my center. And coincidentally, it has so happened that if we consider that total, there are about 350 practicing gynecologists in Sri Lanka. A little more than 100 of them have been to Akola for the training course.
That's quite remarkable.
Yeah. So it's become sort of a routine for them that once they are doing laparoscopic work, then they should come and visit my place and get some more tips and get the refinement done. So coincidentally, then happened that in the current body, there was a proposal that since I am comfortable and close to so many Sri Lankan consultants, and they have all been taking training from me, then they proposed that they should be awarding a fellowship to me.
Sure. And I was there when Rajesh received the fellowship. I can tell you it was a very, very nice occasion. And thank you for all the work that you're doing to train people, but even from neighboring countries, on this sort of very special skill. I'd just like to now segue, since you mentioned chocolate cysts. We know that there are so many kinds of ovarian cysts, right? And one of the fears that you have with an ovarian cyst, particularly after a certain age, is that you should not inadvertently operate on someone who has a malignancy. Very true. Because you are essentially upstaging the disease. So what could have been potentially a stage 1 disease then becomes a stage 4 disease. And I think we now have the ability to, in the most large majority of cases, make this distinction right from the beginning. So I'd again like to ask you, in your practice, what do you do to ensure that you don't inadvertently operate on a malignancy? And if you do find that when you put in the laparoscope and you've not really operated, there's not been any spillage or upstaging, you find that there is a suspicion of malignancy, what would you do?
So, as you mentioned, nowadays there are a lot of tests available. So before we plan the surgery, we are able to reasonably filter out the condition that whether malignancy is likely to be involved in this or not likely to be involved in this. If all the tumor markers, the blood tests which are called as tumor markers, which we do for ovarian specifically, if they give an indication that there is no high risk of malignancy, along with that, a color Doppler shows that the blood flow is not within the tumor and it is only in the periphery. If this is a reasonable situation, then I would go ahead and recommend an laparoscopic surgery to the patient. If there is a doubt, if any of the 4 or 5 tumor markers which we do, if any of them show an erased value, then I don't try to take any risk. We refer the patient for an open surgery to the oncosurgeon.
Absolutely.
I think the right person would be an oncosurgeon to operate on such a patient. Now, there are certain circumstances, like you mentioned, that I have put in the laparoscope, and then though the reports have all been in favor of benign, I am not comfortable with what is appearing in front of the scope. In that case, if it is easily possible to take a fine needle biopsy from the surface of the ovary without puncturing the ovary, I try to take some tissue so that we can have a little better judgment. Otherwise, if that biopsy is not possible, it is looking turgid, then I would again abandon it as a diagnostic procedure and refer for an open laparotomy rather than converting it into a laparoscopy and then having a problem with post-operative report coming as malignancy.
Absolutely. So I think there is so much to unpack in what you said, right? Just because you are one of the most eminent endoscopic surgeons of the country, you shouldn't shy away from a laparotomy when it is indicated, because laparotomy is indicated. And for those who may not be aware, a laparotomy means an open surgery where there's an incision on the abdomen. And I must tell those who may not be aware that incisions now are very different from incisions that used to happen in the earlier days. We now have this incision known as a transverse or a phalanx field incision, which is really quite easy to do and is quite good to recover from. And if, again, as I said, if you think that the patient may be better served by a laparotomy, then don't hesitate to do one. Having said that, for the large majority of cases, laparoscopy is the operation of choice.
Yes.
It's only that when there are some circumstances which dictate, you may decide.
So out of my 25 years of practice, what I have learned, it takes 2 years to learn how to operate. It takes 20 years to learn when not to operate.
I so agree with you on that. And I think that's actually the sign of a mature surgeon. I remember that at one point, for example, polycystic ovarian drilling used to be this very, very popular procedure. As someone who has primarily been interested in IVF and fertility from the beginning, I was always quite hesitant to adopt it. And it used to be a little disconcerting when patients had this procedure and they would come with a low ovarian reserve. So I think, again, I cannot agree more with you when you say that it's more important to know when not to operate rather than when to operate and how to operate.
Not because I'm getting into IVF, but I do agree with the point that IVF has replaced laparoscopic surgery for most of the tubal problems, not only for unhealthy tubes. Earlier, we used to make an attempt to even repair the unhealthy tubes and see if the patient can conceive with knowing the higher chances or the risk of an ectopic pregnancy happening. But even in healthy patients where the tubectomy has been done and for some reason the patients want to conceive again and they approach for a tubal reversary, the natural choice to be offered that if they can afford to go in for IVF as a first choice, in case financial implications are playing a role, then we offer the choice that we can do a laparoscopic reversal or joining the tube again. I think from my personal perspective, the only place what has a role right now is hysteroscopic tubal cannulation to open the minor blocks in the tube.
Sure.
So the tubal block is either just a minor plug or a diseased or damaged tube. So the moment it comes to a diseased or damaged tube, nothing to be done either hysteroscopically or laparoscopically. IVF is a safer bet in the long run. A minor block because of a mucus plug, which can be flushed with some effort with hysteroscopic catheter, is definitely going to have an advantage in allowing the patient to thrive from
matching and suction. And I think this, in a way, reflects the fact that IVF is so much more successful than it used to be.
and safe and convenient.
So, for example, there used to be a time when the success rate of an IVF cycle was so low and the expenses were so high that the cost-benefit ratio used to weigh in favor of surgery. We are now at a point where the cost-benefit ratio actually weighs in favor of IVF. So I think I take your point very well that if you can flush out some mucus plug or debris which are blocking with the hysteroscopy, that's all well and good. But if not, then for a diseased tube or even a tube which has, for example, been cut because of an ectopic pregnancy or even a tubectomy, I think an IVF would probably be a better option. So thank you very much, Rajesh. Always a pleasure chatting with you, and welcome to Pluro. And again, all the very best for your NAPCO center.
Thank you very much, Jaydeep. It's really been a pleasure interacting with you and discussing with you today. I really look forward to our long-term partnership.